We are starting a unit or a chapter from therapeutic guidelines, dental management of patients with medical conditions. It starts from page 153 of these guidelines, and very important topic. In asking questions, they would say that this patient came to your clinic for replacement of dental filling, and the patient would be having some condition, medically compromised condition, diabetes, or would be on medication for blood thinners, something. And in the subsequent questions, they would ask questions regarding medical management of that patient. So like, what steps would you take in managing that patient? And very important topic for ADC per se. Now, patients attending general dental practice can have medical conditions or be taking medications that affect their dental management. And it is important to obtain complete medical and medication history. We have already outlined the history taking in dental practice. For patients with a medical condition, consider the potential effect of dental treatment on their condition. If the patient can only tolerate short periods of dental treatment or their medical condition is easily destabilized, modify dental treatment accordingly. For patients with complex medical conditions, schedule appointments in the morning so that any potential sequelae can be resolved. So it is a very important point. Schedule appointments in the morning for any complex medical condition. Basically, they mean to say that for any medical condition, morning appointments should be scheduled. Then if the patient's life expectancy is short, or if they have severe disease, consider whether dental treatment will improve the patient's quality of life and level of pain. So terminally ill patients also can be taken in for treatments which reduce pain, improve quality of life. Consult the patient's medical practitioner, specialist, or multidisciplinary team to determine an appropriate treatment plan for acute oral and dental conditions. So in case there is an acute oral dental condition emergency, suppose a patient with a spreading infection, oral infection comes, and the patient is diabetic. You do not know the diabetes management status. So you would refer this patient to hospital because their medical practitioner would be present. And if a condition is such like you need to do immediate access opening, you will again take permission from medical practitioner if the clarity of medical history is not there. Then the following topics outline the common medical conditions and medications and dental issues associated with them. They are not a substitute for formal training or detailed texts. Medical emergencies can arise during dental treatment, and call 000, administer first aid. So for that, this is the first aid part of the medical conditions is given later. Then we have antithrombotic drugs. The first thing which is starting is antithrombotic drugs, or we can say blood thinners. These include oral anticoagulant drugs, which are apexaban, dabigatran, rivaroxaban, and warfarin. So all the ban kind of names, warfarin, we know are blood thinners. Injectable anticoagulants, heparin, enoxaparin, and antiplatelet drugs, aspirin, clopidogrel, prasugrel, tecaglor, and dipyridamole. So usually they would use the common names, apexaban, rivaroxaban for oral anticoagulants, heparin. They would not use the very typical names which dentists would not be knowing. Then patients taking antithrombotic drugs are at increased risk of prolonged bleeding associated with an oral or dental procedure. So before any oral or dental procedure, one needs to take comprehensive medical and medication history, included doses and indications. So you need to ask, the patient might say, since they have got their heart surgery done, they are taking 2 small white pills. Now, it is enough to suggest you that it is some particular type of blood thinner. So try to take in details. Do they know the name, since when they started, and everything possible. If they cannot give you details, you have to consult their medical physician who is under whose care the patient is. Particularly note of use of any anticoagulant or antiplatelet drugs, including non-prescribed aspirin and any other drugs with antithrombotic effects like NSAIDs, complementary medicines. When planning oral or dental procedure in a patient taking antithrombotic drug, weigh the potential harm of continuing a drug that may increase the risk of prolonged bleeding against the risk that stopping the drug could cause thromboembolic event, which is far more highly lethal than just taking measures to control bleeding while doing that surgery. So for risk assessment, we would see below. Many common dental procedures have a low risk of bleeding, and the consequences of a thromboembolic event are usually more significant than consequences of bleeding. So stopping the medicine is far more dangerous. However, bleeding can be unexpected and potentially life-threatening. So we have to seesaw between risk-benefit ratio here. In dental practice, consequences of thromboembolic event are usually more significant than consequences of bleeding. So they are weighing thromboembolic event as a darker and more serious event. Temporary interruption of antithrombotic therapy is sometimes necessary to reduce the risk of prolonged bleeding. So we would have, if need arises, temporary interruption may be required, but it should only be done in consultation with the clinician managing the drug. As a dentist, we are not stopping the medicines ourselves. Only consult the clinician managing the drug, and then our role goes only towards consulting them. They would be the one to guide us on stopping and further ahead. So then we have risk assessment for patients taking antithrombotic drugs and undergoing an oral or dental procedure. Now, risk assessment for patients taking antithrombotic therapy before an oral or dental procedure includes consideration of properties of these drugs, whether they are antiplatelet drugs or heparin directly or anything. Patient-related bleeding factors, procedure-related the bleeding risk, and the likely clinical effect of bleeding or thrombosis should it occur. So procedure, say an impaction surgery would produce more bleeding than just a normal extraction. So what is the level of procedure and likely clinical effect of bleeding or thrombosis should it occur? To assess peri-procedural bleeding risk, dentists should obtain accurate medical and medication history, which may require consultation with patient's medical practitioner. Again, they have stressed on it. Risk assessment also includes assessment of patient's overall capacity to provide an accurate medical history, understand and consent to the procedure, and understand and adhere to post-procedural care requirements. Then clinical judgment is required from both the dentist and the clinician managing the antithrombotic drug to determine if temporary interruption is necessary. So both have to, in consensus, determine temporary intervention is interruption of the thinners is necessary or not. And we would see the approach for managing patients taking antithrombotic therapy in oral or dental procedures in pages ahead. So we have first antithrombotic drugs. Now we have antithrombotic drugs. Now antiplatelet drugs, which platelets are basically, they form the initial plug at the bleeding site, and they control and they cause bleeding interruption temporarily. Okay, that's what their function is. There are the first mode of action where they collect there and form the plug. The clot stabilization happens later. So if a patient is taking these antiplatelet drugs, their bleeding will be prolonged. Okay, so there are two things. One is bleeding and other is coagulation. Platelets help at the stopping bleeding part of it. Coagulum takes a little while to form. So anticoagulants are the ones which are stopping the later on scenario, and there are they do not let the plug become firm. It will be lost if we do not have proper coagulation factors in the body, which are factor 8, factor 9. Okay, so there is the work of these coagulants in the creation of a clot and arresting the bleeding. Now, antiplatelet drugs are the ones, one of them is written P2Y12 inhibitors. They are clopidogrel, prasugrel, ticagrelor, aspirin, the commonest drug which is given as which is given as blood thinner, and dipyridamole. Now, some patients take non-prescribed aspirin also. So, elderly in many countries, they will start taking because the risk of heart disease increases, and as age advances, they will start, it's over-the-counter drug available, and they will start having aspirin to not have heart conditions. Then dual antiplatelet therapy, like aspirin plus any of these, clopidogrel, prasugrel, or anything, is usually prescribed for a specific duration. Early interruption of dual antiplatelet therapy increases the risk of ischemic events and thrombosis. So, in patients who are on both the drugs, if we suddenly stop, it would lead to ischemia or thrombosis. Then we have the second is warfarin, which is an oral anticoagulant that inhibits the production of vitamin K dependent coagulation factors. The INR ratio, which is the internationalized normalized ratio, indicates the extent of anticoagulation in patients taking warfarin. So always remember the INR is valid only for warfarin and not other drugs. And the target INR varies depending on indication for therapy. INR should not be relied on solely to determine the bleeding risk in patients taking warfarin. Other determinants of bleeding include concurrent drug therapy and other patient factors. The non-vitamin K antagonists, oral anticoagulants include direct thrombin inhibitors like dabigatran and factor 10A inhibitors, example apixaban. So these are oral antagonists, but non-vitamin K ones. So they directly prevent thrombin formation, and thrombin formation is needed in the last part of that bleeding clot formation pathway. So from prothrombin to thrombin, if it is not formed, the clot will not mature, it will not form. And factor 10A inhibitors, which are apixaban, rivaroxaban. So unlike INR in warfarin therapy, there is no test to indicate extent of anticoagulation in patients taking these non-vitamin K antagonists. So INR, as I mentioned, is only working for warfarin pathway. The vitamin K coagulation factors. And then we have injectable anticoagulants. They include heparin. Heparin is always injectable. Okay, there are no drug popping pills for heparin. and low molecular weight heparins, which are enoxaparin. These are usually prescribed for a short duration. Okay, they are heparin is not given for long durations as it's the IV drug. Okay, it is usually given, in fact, for surgeries. When a surgery is to take place for a long duration, they inject heparin so that the blood doesn't coagulate in between. They want vessels to be running. Okay, so that is the role of mostly heparin. Then patient-related bleeding risk factors. We have this box which outlines the importance of important patient-related factors that increase the risk of prolonged bleeding from oral and dental procedure in patients taking antithrombotic drugs. The list is not exhaustive. The patients with multiple risk factors have an additive risk for prolonged bleeding. Now, if possible, address modifiable patient-related risk factors before proceeding with elective oral or dental procedures. Many complementary medicines can affect hemostasis, either directly or through direct drug interactions. So consider stopping the complementary medicine before the procedure. So this is, if you were considering stopping the complementary medicine before the procedure, just you have to consult the physician in charge for that medication. Now, important related risk factors that increase the risk of prolonged bleeding from an oral and dental procedure in patients taking antithrombotic drugs. Patients with multiple risk factors have an additive risk of prolonged bleeding, and risk factors include elevated blood pressure, abnormal kidney or liver function, prior stroke. So those who have prior stroke or BP are anyways at higher risk of bleeding. History, liver in itself plays important role in the in forming the vitamin K dependent clotting factors. So liver kidney dysfunction is also hastening the risk. Then history of bleeding, particularly if this has occurred in the similar procedure below. You would also have to ask if the patient gets cuts or nicks, does it bleed for long? Or for men, we can ask, when you shave, do you get, and if it cuts the skin, does it bleed for long? Any pre-existing bleeding disorder like hemophilia or any other von Willebrand's disease or anything. Poor anticoagulant control, example, labialine, INR. Then we have older age or frailty. No other drugs that predispose to bleeding, including NSAIDs, non-prescribed NSAIDs, and low-dose aspirin. So if other drugs are there, patient is consuming them, which are to reduce bleeding. And hazardous alcohol consumption. Alcohol is in itself a blood thinner. Okay, it increases the chance of bleeding. So we have procedure-related bleeding risk. What are the conditions which, what procedures are causing more bleeding risk? So oral and dental procedures that are unlikely to cause prolonged bleeding are examination and diagnostic procedures, which include periodontal examination and impressions. It is very important to remember this table also, because the answers to the questions, SBQs, can change based on the patient came for examination or the patient came for, surgical extraction or implant patient. With a history of patient is on dabigatran. So it would be written something like that. But if the procedure is minimally invasive, like periodontal probing, impression taking, restorations, root canal therapy, which is like restorative treatments, orthodontic treatment, it is minimal risk. Oral dental procedures that are likely to cause prolonged bleeding, lower risk of prolonged bleeding, are extraction of small number of teeth, 1 to 3 teeth that are not adjacent. So the At one side, there is not a big wound. Okay. So 1 to 3 teeth, not adjacent, is lower risk of prolonged bleeding. In periodontal procedures, subgingival debridement, prolonged bleeding but lower risk. Incision and drainage of swellings and limited or soft tissue, small soft tissue biopsies. Then we have higher risk of prolonged bleeding if extraction of large number of teeth, 4 teeth or more, or extraction of adjacent teeth that creates a large wound. So 2 adjacent teeth also is a large wound. So it becomes a higher risk of prolonged bleeding. Any procedure where a mucoperiosteal flap is used. Example, surgical extractions, implant placement, periapical surgery, periodontal surgery, wherever you are raising the mucosal periosteal flap. Extensive soft tissue biopsies. Minor small lesion, small ulcer, you are checking. Small, fibroma-like lesion, you are cutting and checking, small risk. But if you are taking soft tissue, extensive region of biopsy, it is a high risk. Hard tissue biopsy, always a high risk. Then the bleeding risk associated with these procedures is based on the consensus opinion of an expert group, and the risk assessment also requires clinical judgment of the individual procedure, patient and drug-related risks of bleeding, and the practitioner's competency to manage prolonged bleeding should it occur. Consider specialist referral for procedures with a high risk of prolonged bleeding in patients taking antithrombotic drugs. Then for specific advice on whether to continue or interrupt antithrombotic therapy, you see patients taking triple antibiotic therapy, anticoagulant plus antiplatelet, single anticoagulant or dual antiplatelet, single antiplatelet, and injectable anticoagulant. So the more the potentiation of whether it's a combination of 2 drugs together or an injectable one, it is increasing the risk. If antithrombotic therapy has been prescribed for a specific period, example, dual antiplatelet therapy for 12 months following an acute coronary syndrome or implantation of a drug-eluting stent, delay elective oral or dental procedure until after this period if possible. So patients scaling and all elective dental procedures can be taken up 12 months after that antithrombotic therapy till when it is on after that. So especially if we have known history of implant placement, stent placement, surgery was done 12 months within this 12 months period. Consider specialist referral, example, oral and maxillofacial surgeon or periodontist, for patients with patient-related bleeding risk factors. So if we have a patient and if we cannot electively defer the treatment, refer them to the surgeons and periodontist, or procedures with higher risk of prolonged bleeding, then also refer them to, safest to refer them to the specialists. For procedures of a long duration, consider limiting the extent of surgery performed in one sitting or referring to a specialist. Consider specialist referral for patients with patient-related bleeding risk factors or for procedures with a higher risk of prolonged bleeding. And below table outlines local hemostatic measures for oral and dental procedures in patients taking antithrombotic drugs. What are the local measures you will, as a clinician in your general dental practice, will take to control the bleeding in these patients who are taking these drugs? Okay, it would be something more than what we do for normal healthy patients. So we would apply pressure to wounds. Pressure is the most important factor in achieving hemostasis. Minimize tissue trauma. Be as gentle as possible in raising, even reflecting mucosa if you are doing, extractions. So minimize the tissue trauma and place cellulose and collagen if indicated. They act as in the sockets. You can place cellulose and collagen. They will create a plug. Place sutures to enclose closure of the wounds if indicated. Consider using tranexamic acid 4.8% mouthwash as an adjunctive measure for patients taking warfarin. Tranexamic acid mouthwash can stabilize a blood clot in patients taking warfarin. So it is an important thing to remember, tranexamic 4.8% mouthwash. There is no evidence on the use of tranexamic acid mouthwash in patients taking the non-vitamin K ones, okay, the newer anticoagulants. So it is only for patients who are taking warfarin. Apply tranexamic acid mouthwash topically just before the surgery, and after the procedure, give patient this 4.8% mouthwash with instructions for use. What is the instructions? 10 ml rinsed in mouth for 2 minutes, then spat out 4 times daily for 2 days. So it is maybe available in the pharmacy, but if it is not available, you can create this solution by crushing the tablet of tranexamic acid 500 milligram, dispersing it in 10 ml of water immediately before administration. So it has to be freshly made every time. It is essential to provide patient with written information on post-procedural care. So whenever you are doing a surgery for a patient who is on warfarin, say, so you would give a detailed post-op care, including contact information in any emergency. Advise patients to seek urgent medical attention if there is persistent ooze or bleeding that restarts, or any bleeding of concern. Advise patients that they may have extensive bruising. Advise patients to seek urgent medical attention if there is persistent ooze or bleeding that restarts, or any bleeding of concern. And we have paracetamol is the preferred analgesic for post-operative pain in patients taking antithrombotic drugs. Concomitant use of non-steroidal anti-inflammatory drugs and antithrombotic drugs increases the risk of post-op bleeding. And like NSAIDs, for example, like aspirin, and combined with it, any of these antithrombotic drugs, it potentiates the bleeding tendency. So NSAIDs increase the risk of bleeding in patients taking anticoagulant antithrombotic drugs. Arrange a review of dental appointment for 2 days after the procedure for checking bleeding, pain, delaying healing or infection, and treat as necessary. So how would you prescribe a patient who has underwent extraction in your clinic who was on antithrombotic for painkillers? You would choose paracetamol. You would not choose ibuprofen or any other drug. Celecoxib, rofecoxib, nothing. Paracetamol for patient who underwent extraction who was already on any other anticoagulant drug. For patients taking triple antibiotic therapy, example, dual antiplatelet therapy plus 1 anticoagulant, consult the clinician managing the antithrombotic therapy before performing any oral or dental procedure. Consider specialist referral for the procedure. The patients taking an oral anticoagulant plus an antiplatelet drug undergoing an oral or dental procedure. So here a combination of, we have oral anticoagulant plus antiplatelet, okay? So undergoing dental procedure. So this combination is something like apexaban and aspirin, okay? These patients have a high risk of prolonged bleeding because of the combination of antithrombotic drugs used. So in the clot mechanism, we have the drugs which are antagonists to both the things. One is plug formation, they are taking drug for that, and other is the plug to clot formation, they are taking drug for that also. So it is very critical, they are at very high risk of bleeding. First, the plug will not form, and then on the top of it, clot will not mature. Therefore, there is a lower threshold for considering temporary interruption of antithrombotic there is a lower threshold for considering temporary interruption of the antithrombotic therapy in consultation with medical practitioner. You can do this interruption temporarily or referring the patient to a specialist for the procedure. So either of them has to be done for these patients because even one extraction can bleed heavily, excessively for these patients. If the patient has had any bleeding, patient-related bleeding risk factors, this further increases the prolonged risk of bleeding. So previous bleeding tendencies, it would increase the chances. If any antithrombotic therapy has been prescribed for a specific duration, delay elective or dental procedures until after this period is, if possible. Then for patients taking oral anticoagulant plus antiplatelet drug, temporary interruption of antithrombotic is not required for the following oral or dental procedures. The ones in the table which are like normal checkup or what were the other two simpler ones? It is checkup, bracket placement, orthodontic treatment, and restorative treatments, which are restorations and root canal therapy. So you need not stop the drug for these three procedures. But periodontics, yes, because it can bleed heavily on scaling, but not in root canal therapy. Then we have the next part. Consult the clinician managing antithrombotic therapy to determine if temporary interruption or specialist referral is required for the following dental procedures, which are procedures with a lower risk of prolonged bleeding or higher risk of prolonged bleeding. So you will consult the clinician first, okay? And the clinician will make a judgment whether to stop or we refer to specialist. So in these two also, you need not make a decision according to guidelines. They say that you ask physician first, consult him, clinician will guide whether to stop the drug temporarily or what to do with the procedures like scaling or, extractions with these patients. If temporary interruption is required, follow the advice from the medical practitioner. If temporary interruption is not required for the patients taking warfarin, also consider current INR and stability of this INR. Recheck the INR within 24 hours before the procedure. So this is very important that even if the patient has had INR done a month back, 24 hours before procedure for warfarin taking patients, we have to recheck INR values. Provided INR is 3.5 or less, perform the procedure. So if INR is less than 3.5, you perform the procedure. Do not perform the procedure if INR is more than 3.5. Refer the patient for medical assessment and stabilization of this INR. Use local hemostatic measures, cellulose plug, collagen can be added on in the clot, in the socket when performing any oral or dental procedures in a patient taking antithrombotic therapy. For procedures performed in patients taking an anticoagulant plus antiplatelet, use local hemostatic measures as described above and follow general management advice to minimize bleeding risk. Advise patients that they may have extensive bruising and to seek urgent medical attention if there is persistent ooze or bleeding that restarts, or any bleeding of concern. Then we have the next part, patients taking single oral anticoagulant or dual antiplatelet undergoing an oral or dental procedure. So this is an antiplatelet and oral anticoagulant is a more chances of bleeding is more with that than single anticoagulant or dual antiplatelet. At least one pathway is working fine, okay, in this. So advise patients, this advice applies to patients taking either a single oral anticoagulant or dual antiplatelet therapy. like aspirin and clopidogrel. So if antithrombotic therapy has been prescribed for a specific duration, delay the elective dental procedure or dental procedures until after this period is possible. But for patients on single oral anticoagulant or dual antiplatelet therapy, temporary interruption of antithrombotic therapy is not required for the following oral or dental procedures, which are unlikely to cause prolonged bleeding, simple restorations, RCT, examinations, but procedures, and also for procedures with low risk of prolonged bleeding. In patients without patient-related bleeding risk factors. But you need to consult the clinician managing antithrombotic therapy to determine if temporary interruption or specialist referral is required for following dental procedures. Procedures with low risk of bleeding in patients with patient-related bleeding risk, or procedures with a higher risk of prolonged bleeding. So it is all permutation combination. Whenever either the patient risk factors is rising, previous risk is there, but even you are doing low risk procedure, you have to consult. Or if the procedure in itself is high risk, you have to consult. If temporary interruption is required, follow the advice of medical practitioner. If temporary interruption is not required, warfarin patients check INR within 24 hours before the procedure. If 3.5 or less, perform the procedure. If more than 3.5, refer for medical assessment and stabilization of INR. And for procedures performed in patients taking single